Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's event, Understanding the Basics of Attention Deficit Hyperactivity Disorder. Before we get started, I want to take a moment to orient everyone to the Zoom system so you know how to participate in today's event. Please note that upon joining the conversation, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the bottom of your screen. In order to ensure that we're able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the conversation, and we will address them during the Q&A. We are very excited to have with us today Dr. Anil Chacko, Associate Professor of Counseling Psychology at NYU Steinhardt. Dr. Chacko, welcome, and thank you for joining us.
Thanks so much, Jason. So as Jason mentioned, my name is Anil Chacko. I'm in the Department of Applied Psych in the Counseling Psychology PhD program at New York University. Just to tell you a little bit about myself, I'm a licensed psychologist. I also practice at the Center for ADHD, which is in the Department of Psychiatry at the Icahn School of Medicine at Mount Sinai. ADHD is really both my research area and a significant part of my clinical work. So I'm excited to present today. So just want to go through some of the objectives. ADHD is very broad and there's a great deal of depth. So we're going to focus really on breadth here more than depth. We're going to discuss some signs and symptoms of ADHD, which for folks who work with children should be pretty straightforward. We might just review that briefly. We'll discuss ADHD trauma and stress, or ACEs, and we'll begin to discuss some behavioral interventions for ADHD and some non-behavioral interventions for ADHD, and then hopefully close with best practices and a very brief case illustration of some of the best practices. In the past, I've presented on each of these particular points for 60 minutes or 90 minutes at a time. So just keep in mind that these are pretty significant areas with a great deal of depth, and it will be impossible to cover all of these in sufficient depth over the course of the next 50 minutes. So happy to field any questions at the end and follow up after the webinar as well. So we're going to start off with some early signs. So we already know that ADHD is a mental health disorder of childhood. There's been increasing and pretty convincing data that ADHD presents in early childhood. In fact, going back to the late 90s, there was a big initiative through NIH to begin to reliably diagnose kids, young kids. And we have a pretty good system, not perfect, but a pretty good system that works to reliably identify kids as young as 4 years old. So what about even earlier signs? So there's been some increasing efforts at trying to understand early signs or identify early signs for 3 and 4 year olds. And these are some that are important for clinicians who are working with young families. So if you're working in a primary pediatric setting or an early childhood setting, or if you are working in outpatient mental health that has a focus on really young kids, what are some signs that are useful to know? Some of these are downward extensions of DSM symptoms, so talking a lot or making more noise. Some are downward extensions of DSM criteria that provide more discrete time periods, like losing interest after moments, or not being able to pay attention for more than a minute or two. Others focus on the nature of motor coordination, so hopping on one foot. This is an early indicator of neurocognitive challenges, executive functioning challenges with kids, and maybe a reliable early sign of ultimately of the diagnosis of ADHD. In addition, some additional signs include further, again, some downward extensions of DSM symptoms, restlessness in particular. Lastly, some signs indicate a potential concern for ADHD, really around the inability to control impulses around boundaries. So boundaries meaning people that are unfamiliar, places that are unfamiliar, getting into things without a concern for one's own safety in young kids is particularly problematic in general, but may be indicative of potential ADHD in their near future. So a lot of these kids end up in emergency rooms because of this impulsivity or inability to restrain their behavior in the context of novel settings. So I'm going to just quickly go through the DSM criteria. I'm sure that for folks who work in children's mental health, given the prevalence of ADHD and the comorbidities associated with ADHD, oftentimes when you have a young child, a child who comes in for services, you're going to be assessing for ADHD. And so this may be familiar for many of you. So if you want, this is really important, I think, if you want a DSM diagnosis, which is the classification that we use here, you have to follow the guidelines used in the field trials for establishing a DSM ADHD diagnosis. And that has been subsequently used in research to establish the diagnosis. So what that means is from the field trials, which are used to establish the diagnosis, you need parent and teacher self-report on validated scales of DSM ADHD symptoms specifically. You need assessment of functional impairments. In addition, you need parent interviews of symptoms, and you need an assessment of co-occurring disorders that may better explain some of the symptoms like trauma or anxiety or mood issues. Simply relying on parent report is insufficient. There are a lot of false positives when you base DSM symptoms or the endorsement of DSM symptoms solely on parent report. There is no blood test for ADHD. There are many folks who use a neuropsych assessment for diagnosis, but per the DSM, that is not necessary to obtain a DSM diagnosis. So in terms of DSM diagnosis itself, it's 6 to 9 symptoms for kids, 5 to 9, 5 out of 9 for adolescents or adults across presentations of inattention or hyperactivity, some level of stability for at least 6 months. There has to be some symptoms that occur before the age of 12. For those of you who have been around for a little bit of time, that is actually, this is an increase in the number of the age cutoff. Previously, it was 7 years. And so this certainly will increase the number of kids who potentially meet this particular criterion for ADHD. There has to be some cross-situational presence of symptoms. So symptoms that just occur at home or just at school or just in particular settings is not how we think about ADHD, which is cross-situational. The symptoms have to impair daily life functioning, and essentially symptoms by themselves are not impairing. Some people may be fidget a lot or move around a lot, but when it comes to getting things done in their lives, whether it is work, whether it's school, whether it's relationships, they seem not to be impacted by those symptoms, and therefore those symptoms do not lead to impairment in daily life functioning and therefore should not be endorsed as ADHD symptoms. And of course, we want to rule out for other potential reasons. And ADHD is very comorbid with internalizing problems, with learning disorders, with a whole bunch of things. And so there are a lot of reasons for the presentation of ADHD beyond ADHD itself. Just quickly, these are the standard DSM symptoms for inattention. Everything from making careless mistakes, paying attention, seeming to not listen, inability or failing to follow instructions, organizing, avoiding or disliking tasks that require sustained mental effort, losing things, being distracted and forgetful. Importantly, what's necessary for these symptoms, including the hyperactivity and impulsivity symptoms, is that it often occurs so that it's developmentally inappropriate. And I'll touch upon that again in the next slide. So some typical symptoms of hyperactivity and impulsivity per DSM is fidgeting, leaving the seat when remaining seated, running or climbing, unable to play quietly, being driven by a motor, constantly going, talking excessively, blurting out answers before questions have been asked, difficulty waiting their turn and interrupting or intruding on other people. Sorry. So as I mentioned before, I just want to highlight this again. The simple presence of any of these symptoms, the hyperactivity, impulsivity, and/or inattention symptoms alone does not indicate ADHD. It has to be developmentally inappropriate for the child, and it has to result in impaired functioning. So the mere presence alone is insufficient. It is both the severity and the frequency of those symptoms across contexts that indicate a potential endorsement for ADHD. So here's some questions regarding trauma or ACEs. So we are often asked two questions in our area. Do adverse childhood experiences, which include things like parental loss, maladjustment, maltreatment, do those predict the development of ADHD? This has been a burgeoning area of research and is still really in its infancy, I think, but the answer is yes. So there's a lot of literature in early childhood around adversely related toxic stress that impacts neurohormones, cortisol, and other neurochemicals which are related to brain development, in particular prefrontal cortex, which is associated with symptoms of ADHD. So the prefrontal cortex is where we have inhibition, working memory, planning, all those things that are hallmarks or deficits in kids with ADHD, often deficits in kids with ADHD. So ACEs and trauma do predict the development of ADHD. And the other interesting question is, does ADHD predict the occurrence of ACEs? That the answer seems to be yes. ADHD in particular specifically predicts parental maladjustment later on. So this is even controlling for current levels of parent maladjustment, other mental health disorders in childhood that may predict parental maladjustment. ADHD seems to explain the development of parental maladjustment above and beyond those factors. And interestingly, ADHD inattention subtype is predictive of increased ACEs. So studies have found that inattentive subtypes tend to be less likely to be detected in kids and to be associated with the later initiation and shorter duration of treatment. So inattentive symptoms relative to hyperactive impulsive symptoms tend to persist more into adulthood and remit at a lower rate. So it may be the case that longer persistence of symptoms, especially if they're untreated, might give more opportunities for snowballing effects. So it may be the case that ADHD inattention subtypes or presentations, that are undetected, untreated, or when treated are treated in less duration and more likely to be persistent, results in issues and challenges at the family and parent level, which points to the need for addressing ACEs, ADHD, and parent functioning when we're thinking about families who've been children who've been exposed to ACEs and parents who may be struggling with their mental health or other areas of maladjustment. So is it ADHD or trauma? Unpacking this is very important. It is a pretty substantial area of interest in the literature. In terms of trauma, repeated exposure to trauma can look like ADHD. So here's a couple of points that are important to consider. Exposure to trauma can allow children are hyper aroused, and so when children are hyper aroused, they're unusually sensitive to the signs of danger or threat. And if you're high on alert for danger, you have a bunch of stress hormones running through your body, and it's difficult to sit still and pay attention. So hyper arousal may make it appear that kids are having a difficult time paying attention, but it's actually hyperarousal. Many individuals who experience trauma relive the traumatic event. And so kids, it's not surprising if they're exposed to trauma, may mentally re-experience traumatic events. And when you're paying attention to something that's going on in your mind, it's very easy to look distracted. when you're exposed to significant trauma over time, in particular repeated negative trauma, there are negative attributions that develop. So when you experience trauma, you perceive people as hostile, situations as scary and unsafe. So what may be perceived as high levels of distractibility or not paying attention or impulsive behavior or even aggression may be an attempt on the part of the child to protect themselves because they perceive the environment as scary and dangerous. As I mentioned before, toxic stress exposure to trauma impacts those neurochemicals in the brain that has a direct impact on executive functioning, particularly in developing young kids. So it's not surprising that when executive functions are impacted, it will look like difficulties with ADHD, but the effect is more likely attributed to ongoing persistent trauma and toxic stress. So what do you do about this? Again, this is teasing apart ADHD or trauma is difficult. There are a couple of points to mention. One is determining the history of exposure and the timeline. So do symptoms occur before or after the trauma? This is easier said than done, especially for kids who've had early trauma that's repeated. Sometimes knowing whether there's a family history of ADHD is helpful because it's more likely that because of the genetic component of ADHD, if there's a family history, there's more likely, greater likelihood that this will be ADHD related. Having a variety of ADHD symptoms points to ADHD. So as an example, things like interrupting, talking excessively aren't often associated with trauma or trauma exposure. So when these kinds of things happen, it may more likely be ADHD. Also, there are symptoms of trauma that aren't related to ADHD, like being avoidant of certain things, people, settings, and places. Kids who experience trauma will do this to protect themselves. And so if you're seeing that, that is an indication that perhaps some of these ADHD-like symptoms may be more likely related to trauma. And of course, ADHD and trauma can co-occur. So it's not a either or, it could be both. As I mentioned before, kids with ADHD are more likely to experience ACEs and more likely to, and ACEs are more likely to predict ADHD. So it is a complicated, intertwined set of symptoms and may not be easily separated. And so perhaps a co-occurring ADHD and trauma is the best explanation for a kid's presentation. So now I'm going to switch gears and talk a bit about psychosocial interventions. Now I borrowed from Steve Evans and his group that discussed categorizing psychosocial interventions into two areas: management interventions and training interventions. Now, I want to first say that there are a plethora, a variety of interventions that have been used to try and treat ADHD. It's impossible in any one setting actually to go through all the literature and discuss the literature, the breadth of it related to treatments for ADHD. I'm highlighting those that have been most well studied. And so there is some empirical literature to draw from to be able to make statements about the utility, usefulness, efficacy of these interventions. Again, this is not to say that there aren't other well-studied or studied interventions that aren't included in here. It's just really thinking about what is the scope of the review here, and really what are the interventions that are most often discussed in at least in the research field, and largely in also in many of the clinical literature as well. So the management interventions are really parent training or behavioral parent training, classroom management, and peer interventions. They're called management interventions because these interventions actually are directly involve key adults in the child's life who manage impairments associated with ADHD through interventions. that are based on operant conditioning and social learning theories. Those are really management interventions. So for folks who think about behavioral interventions, it's really adults who are implementing approaches to the child. Then the second sort of branch here are training interventions. And these are interventions that focus on training children to use skills or directly train children's underlying biological functioning. And so some important points here is what we know is that the first line psychosocial interventions for really the past several decades have been the same. Both the American Academy of Pediatrics, the Society for Developmental and Behavioral Pediatrics, the American Psychological Association, all put forward that the management interventions are the first line interventions for the treatment of ADHD. And again, these all have been conducted in numerous studies, different age groups across the United States and internationally, with pretty consistent findings. So we'll talk briefly about that and then get into some of the training interventions. So psychosocial interventions really are social learning and operant conditioning, are based on social learning and operant conditioning principles. In a very general sense, they are creating clear structure and expectations for kids. I think it often misunderstood about behavioral interventions that for a lot of the initial part of behavioral interventions focus on relationship building through praise and parent-child or teacher-child positive interaction. So developing really that relationship. And then from there, there's an emphasis on different ways of reinforcement, shaping, and proactive discipline. The idea behind psychosocial interventions, of management interventions, is that because executive functions for kids, for most kids with ADHD, is a deficit, increasing rewards, increasing structure is a scaffold or helps support underdeveloped executive functions. And that's an important sort of somewhat of a rationale for why management interventions are used. We know that the consensus across the literature is that it has significant effects on oppositional conduct problems, on task behavior, parent-child relationships. There's less benefits on ADHD symptoms when compared to medication, and seems to have some limited benefits on academic outcomes. So behavioral interventions will not teach you things. It will manage behavior. And so it will not teach you how to be better at academics. You have to learn and use skills in order to directly benefit in those areas. Some of the limitations, generally, these are two probably the most important ones. Russ Barkley and his colleagues have long argued that, and this makes sense, that behavioral interventions, management interventions are really a prosthesis. They are efforts at helping support a child. So it only works in the setting in which it's implemented. So you're not going to get generalized effects. So if you do work with parents around management interventions, don't expect the child's behavior to improve at school or with their peers out in the playground. In order to improve those areas, there's a concept, point of contact. You have to treat the area in which the child is impaired if you're trying to use psychosocial management interventions. Not surprisingly, because you're not teaching skills, you're just really scaffolding and supporting a kid. There's no evidence that there's really significant longer term benefits. Obviously, this is a very difficult question to study. You can't have interventions that run in research for years and years and years. One of the main arguments recently about the issues or limitations of management interventions is that it doesn't address the underlying pathophysiology and or compensatory mechanisms associated with ADHD. So it doesn't actually treat underlying executive function problems, which are often noted as big deficits in kids with ADHD. It helps support those things, but once you remove those supports, executive functions aren't actually improved. They remain still as deficits. And so not addressing the underlying mechanism or problem is not going to result in improved longer term outcomes or generalization of effects. So, and the next branch here is training interventions. And these again are those that directly target the child. As you can see here, one of these is highlighted in black or in black bold type, and the rest are in blue. And that is because there's a distinction here in terms of the evidence base or the research literature around the efficacy of organizational skills training relative to the other 4 areas. And we'll talk a bit about that as well. So organizational skills training interventions, what is it? So this is directly teaching a child how to manage their time better, how to organize their materials better, how to plan for activities, particularly things that are longer term, and to schedule things appropriately. This is very much related to academic interventions, but even though it's directly taught to children, it requires active support from parents and teachers. So expecting a child to learn skills without adult support in implementing it, adult support and reinforcing it, it's going to lead to, it's highly unlikely that a child will use those skills. So even though it's directed toward a child, it often involves, not often, it always involves pretty active support from parents and teachers. This intervention in particular has been developed by Howard Abacoff and Richard Gallagher, who are colleagues at NYU Child Studies Center. Abacoff retired recently and Richard is still there. And the challenge with this particular intervention, although it has some good, strong research evidence, is that it requires twice a week, weekly sessions in order to obtain the kinds of benefits they see in the research trials. So as you can imagine, for a typical family, that is difficult to do, to schedule in twice a week sessions for 10 weeks. There is no data about what happens if you do it once a week. It's likely that it's going to be less effective. So we want to keep organizational skills training interventions, and when I say that it's efficacious, with sort of that caveat and an asterisk that the extent to which it can be applied in routine clinical practice, the way it's applied in research is probably that disconnect is important, and it may confer less benefits. One of the great things that that this intervention focuses on is, instead of kids with ADHD, they recruit and specifically enroll kids who have a deficit in organizational skills. So unlike the vast majority of studies that focus on inclusion based on an ADHD diagnosis, studies that have focused on OST include kids who have ADHD and a documented organizational skills deficit. And the way in which Abacoff and Gallagher have determined this is they developed a, it's called the COS, or the Children's Organizational Skills Scale, which documents or highlights items around organizational skills, and parents and teachers report on those. And if a child actually has a deficit and they have ADHD, then they are included in this intervention. So targeting the right kind of child with ADHD is really important as well. And that's actually an area that's understudied in ADHD, actually targeting kids who have a deficit rather than just meeting criteria for a diagnosis. Neurofeedback interventions have been studied for decades, and neurofeedback is an intervention for ADHD based on the finding that many individuals with ADHD show low levels of arousal in their frontal brain areas. Remember, again, the prefrontal cortex is the area where a lot of executive function happens, and that is associated with ADHD. Specifically, excess of theta waves and a deficit in beta waves. And proponents of neurofeedback suggest that the brain can be trained to increase the level of arousal, so increasing the beta waves and then reducing the theta waves, and therefore reducing ADHD symptoms. This involves often including placing electrodes on a person's head to monitor brain activity and giving them feedback, which helps them perform differently, perform in a way that helps them regulate those their level of arousal. And that's been studied for actually quite some time, and that is another intervention. We'll talk a little bit about the effects of that intervention. And then probably most recently out of all the kinds of interventions, actually that's not true. Some of the more recent interventions in the last, since 2005, there was a seminal article published that focused on an intervention called CogMed, working memory training. For those of you who are familiar with the ADHD literature will certainly have come across this. This was sort of a game changer in the field. For a long time, individuals felt executive functions were pretty static. You couldn't change them. Whatever working memory capacity you had, that's what you had. And it can't actually be changed. CogMed was one of the interventions that's purported to actually change working memory in kids with ADHD. And there's been a burgeoning area of research work in this area of using games, often computerized games, to directly train aspects of executive functioning, things like working memory, response inhibition, sustained attention, etc. The premise of this game is that you can, using a game-like video game structure, you can help kids specifically focus on executive functions, and through adaptive training, which is essentially things get more difficult the better you get, and a little bit easier when you're struggling, you are building that brain muscle or that executive functioning deficit. And given the relation between executive function deficits and ADHD, improvements in executive function should relate to improvements in ADHD symptoms as well. And there are now, you may have also come across in the summer of, summer of 2021, the FDA cleared Endeavor, which is a computerized game for ADHD. It's available by prescription. We'll talk a little bit about, FDA clearance is different than reporting on the efficacy of Endeavor. The data around Endeavor is actually not very promising. And so even though the FDA has cleared it, it is not actually, very effective for ADHD symptoms. In fact, certainly happy to talk about that. That's a sort of a complicated kind of thing to unpack to understand the details, but certainly executive functioning interventions have been studied. And just to say also that this is primarily computerized interventions, but there are interventions around supporting executive functioning that are play-based, that are between parents and kids, using play games, or games that tap into and support executive functioning. Good old classic games like Simon Says and hopscotch and jump rope, but things that require motor coordination, things that require working memory, all those kinds of things are often embedded in some of these child games. And so parents and kids playing those together has been a focus of some of those executive functioning interventions. Although again, this is mostly done in the format of computerized games. Diet and exercise. So the environment, particularly what you put into your body, has been the focus of attention, and this isn't surprising. Our food environment is horrible, and it's full of junk and additives and other things that are not healthy for brain development or your body in general. So there's been a pretty big movement in general about eating clean, organic foods, etc. And this has certainly been discussed in the field of ADHD, really to understand food allergies and sensitivities, with a focus on elimination diets and adding certain kinds of foods as a way of addressing overall health that's related to issues of attention and activity level. We also know that exercise is really important and generally healthy, and there's a large evidence base around exercise and neurogenesis, so brain development, particularly in young kids. And so not surprisingly, given the relationship between brain development and ADHD, there's been some efforts at also thinking about, well, how can we include exercise as a way of improving neurogenesis? All of these aren't necessarily specific for ADHD per se. Exercise in general is just a healthy thing to do, and it's certainly been considered an option for ADHD, and has been studied more recently by Betsy Hose's group and some colleagues. So effect sizes for ADHD symptoms. So this is sort of an important graph here, and just illustrates what is the impact of these interventions on ADHD symptoms. So just to put this in context, on the y-axis here, those are the effect sizes. Anything less than 0.2 it essentially means no effect of the intervention. Between 0.2 and 0.5 is a small effect. Between 0.5 and 0.8 is a moderate effect, and 0.8 is large. And this is the intervention's effect on ADHD symptoms. And as you can see, at the most, neurofeedback is approaching, is a small effect at most, with everything else being much smaller. So these interventions don't seem to have the same impact as medication. What's not listed in here is behavioral therapies or the management interventions. Those end up being around 0.7. So even in relation to management interventions, neurofeedback, exercise, diet, and executive functions don't seem to have as robust an effect. Of course, these are just ADHD symptoms. Unfortunately, this is the only consistent outcome reported across studies. So this is the metric that's used to compare interventions. But this is not to say that some of these interventions can't be helpful. In fact, exercise and diet is good for everybody, whether you have ADHD or not. And maybe it has a significant impact on a particular child with ADHD. But regardless of whether a child meets criteria or doesn't, whether a child is in services or not, paying attention to diet and exercise is important. And this is really just part of good health. Being careful of the foods that you eat and don't eat, and having consistent exercise has some generalized benefits. These, in addition to sleep, is really important when it comes to just basic foundational things that we should be teaching and supporting families. That has a direct impact on attention activity levels. So, one of the things that I often work with families on is making sure there's really stable routines around sleep, nutrition, and exercise, just because it's a healthy thing to do. Easier said than done. Our environment doesn't promote eating healthy. It's expensive to actually do that. And so for some families, they don't have options. And we're in this pandemic, and many of our social interactions and opportunities to get out there and to use our bodies is even limited now. And so all these important healthy habits that we want people, adults and kids, to use, it really does depend on context and your resources that are available to you. So some of the limitations, and I'll just briefly highlight these, is that often there's an underestimated, so executive function interventions, unlike organizational skills training, where, as I mentioned before, organizational skills training focuses on kids with ADHD with a documented deficit in organizational skills. Executive functions those interventions seem to focus on kids with ADHD, whether or not they have an underlying executive functioning deficit. And so because of that, it might be a mismatch between what the intervention is targeting and whether you actually have a deficit that can be improved upon. In the executive functioning literature, there's a misspecification of treatment targets. And what I mean by that is most the literature on ADHD and executive functions seem to focus on working memory as a primary executive function that is a deficit for kids. Most of the executive functioning interventions don't target working memory. They target other areas like response inhibition, sustained attention, et cetera, that are, relatively speaking, secondary deficits to working memory when in its relationship to ADHD symptoms. And many of these executive functioning interventions also have low potency, meaning that they are utilized in a generally weak way, not long enough, not enough duration or intensity. So an area of increased research is actually increasing the specificity, potency, and intensity of these executive functions, with some emerging data that suggests there are some potentially new, not ready for prime time yet, interventions that may be beneficial. Other limitations of this general literature include the quality of the research. So both neurofeedback and exercise have been studied, but studied in designs that are not particularly useful. Then we have some interventions are difficult to implement, like food restrictions, especially in the environment we live in. So it requires, as I mentioned before, money to eat healthy, which makes this difficult. So it's very easy to be able to say, well, you should eliminate this and add that. That's if you have the resources actually to be able to get high quality food and to be able to, have a variety of high quality food that your children can eat. So this is sort of like, these are still areas of research that are promising. There are folks who are doing some interesting work in incorporating exercise into school systems, other work on more novel approaches to neurofeedback and executive functioning. So all these, give it a couple more years, and it's certainly going to be the case where we will have more literature that can speak to the benefits of these approaches. Okay, so best practices. So how should I help the child in front of me? So, we do not treat disorders, or I don't treat disorders. I support kids and their families. And so for me, it is these interventions that have a lot of research support are important, but they are just part of what it means to support kids and families. And I'm sure I have like-minded colleagues who are listening in on this webinar who would certainly agree that a diagnosis of ADHD doesn't really explain a lot. There's a saying, if you've seen one kid with ADHD, you've seen one kid with ADHD, because their presentation is so different from one child to the next. So we have to think about children and families holistically. As I mentioned earlier, for a lot of kids, foundational things like routines, sleep, nutrition, and exercise are really important lifelong habits, and often think about that when working with kids with ADHD and their families, given especially the impact of sleep and exercise and nutrition on symptoms of ADHD, like attention in particular. Having good sleep, getting good quality nutrition, and getting out there, moving your body around is really important. We need to understand the profile of the child, both the weaknesses and their strengths. Address deficits through skill building and supporting key adults in their environment to scaffold and support learning, but also understand strengths and leverage those as well. Understanding the family, both their challenges and their strengths, and then integrating the child and family and broader context. So kids live within families, families live within communities, and communities are also important to consider when you're thinking about access to resources, supports, limitations, and challenges. We certainly want to be sure that we use the evidence base to support what we decide to do, and we want to tailor the profile of the child and the family to ensure that the interventions you're using are targeting a mechanism that is related to an outcome. So simply applying an intervention because it's quote unquote evidence-based is not sufficient. you have to have a strong rationale for why that particular intervention is going to improve a particular mechanism that's related to a particular outcome. And that outcome may include ADHD symptoms, but typically we don't target improvements in symptoms, we target improvement in impairment. So if a child is struggling with their peers, that's an area of impairment. And if that is because they lack social skills, then we will work with parents and other adults to help support and teach those skills and reinforce those skills in peer relationships or peer contexts. Simply because you use an intervention that's quote unquote evidence-based for ADHD doesn't mean that everyone's going to benefit or benefit equally. So progress monitoring, determining whether what you're doing is working is really important, both to inform what you're doing, but also to change what you're doing so that you can be sensitive and timely in your response to interventions and the interventions that you're using. As I mentioned very early on, ADHD is very comorbid with several mental health disorders, and so it's not uncommon for individuals, kids with ADHD, to have specific learning disorders, other behavioral challenges. They're often, as I mentioned before, going back to trauma and ACEs, parent-level factors that impact parenting, which impacts kids' behavior, and then adverse childhood events that impact the presentation and persistence of ADHD. So working with kids with ADHD means you're working with really, on a case-by-case basis, very unique kids. So just briefly, this is a very simple case example. Again, didn't want to get complicated given the time limitations that we have. This was a child, John, who I worked with for 2 years, and he had combined presentation with some oppositional behavior and documented organizational challenges based on the children's organizational scale. So that's sort of a little bit, obviously he's more than just these 4 bullet points, but some highlights here. Whoops. In terms of his areas or challenges, he had challenges interacting with some key people in his lives, his parents, his siblings. He was pretty good with his teacher, although his engagement academically was poor. And that was largely related to some challenges with organization, time management, and planning. Mom was dealing with some significant depressive symptoms. He had a lot of strengths. He was a likable child. He was really a comedian. He was hilarious. He had a loving and connected family, even though Mom was going through some of her own personal mental health issues. She was very devoted to her family and her kids. He was the youngest of several siblings, and the older siblings were very much connected to John and also very resourceful. And so what do? You know, I always start with the end in mind and ask parents, there are varying ways of thinking about this. There's the good old classic miracle question. If you woke up one day and a miracle happened, what would you see, feel, hear, think that made you realize that in fact a miracle happened? And a part of asking questions about what is important to you as a parent is to help understand what are the things that you should prioritize first. You can't do everything, you can't do it all at once. I'm presenting this as sort of the static presentation, but as I mentioned before, I worked with this family for 2 years. And so this was an unfolding of interventions over time. We really focused on family because that's where Mom, that's what she was most interested in. That's what was important to her. So we utilized behavioral parent training principles through the MATCH manual. There are many manuals for behavioral interventions that focus on sort of the common elements, and this is what we use, or I used. We leveraged siblings as role models and worked with the family as a unit. So even though I directly worked with the parent around some parenting skills, we also included a lot of family time to talk about expectations, roles, how older siblings can help support Mom and help support John. In terms of school, I did some parallel work, working with school around some basic consultation around management, utilizing some of the same principles that we use with parents. And then I started working later on with the child around organizational skills training using a once a week model, simply because twice a week was just too complicated. And then I did a lot of support to mom. I check and connected often about her stress and the stability of what's going on in her lives. We spent a good time problem solving and supporting her and her efforts to be the best mom she could be at the time, and referred her eventually to addressing her own mental health, which was sort of at the latter end of our time together. And just like, as I mentioned before, it's the kids are not just a bunch of deficits and weaknesses. They are certainly have a lot of strengths, and John did. And so we identified other areas of interest that he was motivated with: art class, an online comedy class, and even leveraged the home situation, the school situation, where he became a teacher helper, given his how much he was liked and by his peers and his teacher. That seemed like a straightforward and easy thing to do. So I'm just about out of time, so I'm going to stop here and just open it up to any questions. Happy to field anything, and I'm just going to move it over to Jason, who will facilitate.
Great, that was awesome, Dr. Chaco. Thank you so much for the presentation, and I'll just jump right into questions. So the first question is, do you anticipate more young children with ADHD-like behaviors as a result of the stresses from the pandemic?
Yes. I think if the last 2 years have been any indication of the impact of COVID on the mental health of young people, children, there's every reason to think that issues like ADHD is going to increase. So if kids are not able to get out, to connect with their peers in traditional ways, to be able to navigate life, to learn from their mistakes, to be bottled up all in one place, staying in front of a screen for learning, etc. I anticipate that there'll be challenges with attention. There'll be challenges with motivation, activity level, etc. Whether this means that these are going to result in ADHD per se, or just increases in kids who have increased number of kids who have challenges with paying attention, I'm not sure, but it's certainly going to have some kind of impact.
Great, thank you.
And just to also say, I've already seen this in my clinical practice. The number of typically during the summer, just as an example, typically during the summer, we really don't work a lot with families. They're off, they're on break. Over the last 2 summers, the number of kids that I've been working with throughout the summer has been pretty significant, if that's any indication of need.
That makes sense. Okay. The next question really pertains to the organizational skills training interventions. Are those meant for in-person use, or can they also be used virtually?
So they've been studied for in person. This is all pre-COVID. We have been doing things virtually. Can we say that it mirrors the experience in person? It certainly does not. I think you lose quite a bit of the nuances when you're doing it virtually relative to in person. But again, this is sort of the circumstances that we're in. I think our practice has moved into more in person. And so we're trying to ensure that, especially for kids, I think kids benefit from being in person, especially when they're younger, that we try and secure our in-person slots for kids. Rather than when we're working with parents or adults. I think you can do that virtually. That's certainly easier. So the answer to the question, it's not meant to be virtual. You have to make do. I think you lose quite a bit when it is virtual, though.
That is good to know. And just to follow up, many folks are asking, can you point to any resources for the organizational skills training?
Yeah, so there is a published manual out of Guilford Press. It's called Organizational Skills Training by Howard Abakoff and Richard Gallagher. You can get it on Amazon or through Guilford Press. You know, it's, Smart but Scattered, which I'm sure, you know, folks are familiar with. That is also sort of like a executive functioning organizational skills quasi intervention, not intervention per se, but a set um, of discrete strategies that you could use. I use that quite a bit as well um, when I'm just thinking about time limited kind of supports. Maggie Sibley, Margaret Sibley has, and Joshua Langberg also have OST types of interventions that are manualized. Those are for adolescents, and so if you're working with adolescents, that's also a couple of resources. Those are all published and, you know, publicly available.
Perfect. Thank you. And if folks want to check the chat, our host is adding some of those links for those resources. Another question is more so anecdotal. A learner has said that they've noticed that some kids who are diagnosed with ADHD appear to be able to sustain their attention when playing video games. Do you have any thoughts about that?
Yeah, so that sort of goes back to this idea of like scaffolding. When you have a lot of reinforcement and a lot of what happens in video games is that there's a lot of visual engagement, a lot of immediate reinforcement and rewards for behavior. That is essentially like a scaffolding approach to sustaining attention, and that's what we try and do when we're doing behavioral interventions in classrooms and homes. So it's not surprising that a lot of kids are engaged in video games. So the rationale for that is because of the way in which video games are set up to be engaging.
Perfect. A question that came in really pertains to the wider context in social media. So folks have noticed that our attention spans are shortening due to social media as well as many apps. Do you predict that more children will be diagnosed with ADHD as a result of this?
So again, I think that when we're talking about diagnosis of a mental health disorder, we're talking about a small percentage of the overall population that has significant developmentally inappropriate levels or cluster of symptoms. So I don't know if the diagnosis per se will increase, the prevalence of the diagnosis will increase. I imagine, and I think even adults could probably attest to this, that everyone's ability to sustain attention is impacted by the amount of social media or any type of gadgets that capture our attention for short periods of time. So I think there will be more kids with problems in this area. Whether that relates to an actual increase in prevalence of diagnosis, I'm not sure. The one caveat around this is that as I went back in the early part of this presentation, a diagnosis of ADHD per DSM field trials, which established the diagnosis, required a parent and teacher independent report, and then subsequently a parent interview. The extent to which that actually happens in clinical practice is, I know that that does not routinely happen in clinical practice. So as I mentioned before, you will get a lot of false positives if you only rely on parent report of symptoms at home and parent report of symptoms at school. And that is pretty typical for pediatric practices, in fact. So I think most pediatricians, because of just the complexity and the busyness of their practice, generally rely on just parent report. So the prevalence of ADHD may increase in the near future, not because per se that true ADHD has increased, but because more parents are going into pediatrician's office complaining of symptoms of inattention, et cetera, and pediatricians are using not the full assessment approach, a validated assessment approach, but really relying on parent report in isolation.
Perfect. Thank you. And I'm sad to say that we are unfortunately out of time for questions. But Dr. Chaco, I do want to thank you for the presentation.
Thanks, of course. And again, this is my email. If anyone is interested in having a conversation or have some follow-up questions about anything that I have presented on, feel free to contact me.
Awesome. Thank you again, everyone, for joining today's event. Just as a reminder, the slides as well as the recording will be on the CTAC website in 2 to 3 business days. And we do have some upcoming events that we'd love for you to join us on. The first is on January 28th, Obsessive Compulsive Disorder. What is it? How can we help young people experiencing it? As well as 2 peer webinars that are coming up on February 2nd and February 9th. So please do check our calendar for upcoming events, and we'll see you next time. Thank you, everyone.